So thank you. I'm Linda Mahan and a member of the League of Larimer County in Colorado and also of the League of Colorado's Healthcare Committee. And on their behalf, I want to welcome you to our discussion today about a very important concurrence that's being proposed. First, a little bit about the Healthcare Committee. Our League Healthcare Committee in Colorado was begun actually last month to engage members across the state to take action to improve healthcare laws, policies, and systems in alignment with our league positions. And it will coordinate education and advocacy with local leagues and other organizations. And for those of you from Colorado, if you'd like to join that committee, we will be meeting this coming Tuesday at 2 o'clock, February 8th, and you can sign up for that on our league web calendar. And our focus today then for our education will revolve around our national position and a proposed addition to that. And we're very pleased to have over 68 people who had registered for this, and hope that you will all enjoy the discussion. And to keep the background noise down, we do ask that you mute yourself. And for ease of viewing of the speakers, if you go up to the upper right-hand corner in the view and select speaker view, then you'll always have your screen showing the speaker today. And they'll be screen sharing some of their materials, and that will pop into your screen also. We're going to begin with a presentation by the two leaguers, and then that will be followed by a question and answer period. And during their presentation, if you want to put questions in the chat, my colleague Barb Thomas will be monitoring that, and we will ask those questions then after they finish. And also you'll have a time that you can, if you want to unmute and raise your hand, we will call on you and you can ask your question in person. We are recording this today, and this is going to be published on our YouTube channel for the League of Colorado. I think now I'll go ahead and introduce our two speakers joining us from New York. Barb Thomas first joined the League in Billings, Montana, and has been active since the late 1980s in her local league now of Saratoga County, New York, where she has been president for over 20 years at some point in that period. She's also been a member of the board of the New York State League and serves as the issue specialist for both equality of opportunity and for medical aid in dying. She has a master's degree in elementary education and social studies and was the executive director of a 4-county Planned Parenthood affiliate. She co-chaired the Health Care Update Committee that developed the new New York State healthcare positions. And the second speaker, her partner, is Dr. Judith Esterquist, a member of the Long Island, New York League for 5 years, where she has served as the healthcare chair and supported voter services forums and DEI initiatives. Judith has recently been appointed to the New York State issue specialist position for healthcare, and she holds a PhD in English from Harvard, where she taught for a decade before spending the rest of her career, decades, in management consultant with global responsibilities. She was an active member of the New York State Healthcare Update Committee. So thank you and welcome to you all. And I'm going to turn it over to you now, Judy and Barb.
Thank you. Thank you so much. I'm so pleased to see so many people participating today. And I certainly want to officially thank the League of Colorado and especially Linda Mahan for hosting this event. As Linda said, I'm Barb Thomas from Saratoga County, and my co-presenter is Judy Esterquist from Port Washington, Manhasset, which is on Long Island. And we were both members of the Healthcare Update Committee that developed the New York State League's new healthcare positions. We'd like you to list your local league in the chat right now so that we'll know where you're from. And to save time, we are going to ask you to hold your questions till the end, as Linda said. So We'd love it. Thanks. What exactly are we asking you to do? Mainly, we're asking you to recommend this concurrence for consideration at the convention by putting it on your league's program planning survey response. Doing that does not commit you or your delegates to voting for the concurrence at convention. But naturally, we hope that your delegates have some sense of the way your members feel about the issue and do vote for the concurrence. All our concurrence materials are now online and will be there for the next 5 months. The URL to access them is now in the chat, and we will circle back to any specific questions you have at the end of the presentation. And that's a part of what you would see. Concurrence is a very specific league process. It depends on some league entity doing a study and reaching a position. Other leagues can then agree or concur with that position. That is why the wording can't be changed. Concurring with another league's position allows you to have a position without spending the time and resources to conduct a study. A lot has changed since the main part of the national healthcare position was adopted in 1993. And the New York League positions, there were 2, one on healthcare in general and one on the financing of healthcare, were based on studies and updates that dated from 1985 and were last revised in 1991, except for a section on advanced directives that was added in 1999. The easy way to update the national position is to concur at convention with a position, in this case, excerpts from the 2021 New York State positions. We can't change the language of the existing national position without a study, but through concurrence, we can add to it. So how has healthcare and its delivery system changed since 1993? There have been great advances in medical care. Pharmacological treatments have become more effective in curing, treating, or delaying the onset of many serious conditions, even making previously lethal chronic diseases manageable. Complicated surgeries have become more successful. Think heart transplants and now routine joint replacements. But costs have exploded, creating inequities in access. Families spend way more on healthcare than they did in the 90s. And many employers no longer offer health insurance for their employees. Others require increased employee contributions and offer plans with lower premiums, narrower networks, and increased cost sharing, reducing access for even middle-class Americans. And taxpayers are paying more for healthcare too, providing healthcare for government employees, the indigent, the incarcerated, and with pricier privatized care for seniors, long-term dialysis patients, veterans, and others. Americans are now paying twice as much for healthcare per capita as Europeans. We're paying more in taxes for healthcare than they pay for all their healthcare, and they cover everyone. In 1990, healthcare expenditures were 12% of our country's GDP, and now they're 20%. But on important measures, we are not getting healthier. And access now depends much more on where you live, how much you make, and what kind of work you do. Today, fewer Americans can afford access to health care.
Thank you, Barb. The cost of health insurance premiums has tripled over the past 20 years. from an average cost of just under $6,000 to over $19,000 per year, with bigger shares paid by workers. Employers are also choosing plans with greater cost sharing. Healthcare has become prohibitively expensive. The bottom blue and black lines, inflation and wages, have gone up 26%. The green line is premiums, up twice that. And the orange line is cost sharing, which has increased 162%, 8 times faster than wages. This orange line, deductibles and copays and everything you pay after you've paid premiums, plays a huge role in reducing American access to healthcare. It's a cost control method lauded in the 1980s and 90s, which raises total healthcare costs and reduces public health. It's why the Concurrence seeks to add, quote unquote, evidence-based cost controls to the National League position. But doesn't job-based insurance offer equitable access? Well, more high-wage workers get health benefits than lower-wage workers. Let me use some New York State examples to illustrate what federal poverty level means on this chart. In New York State, 90% of families making under $50,000 a year get no health benefits, but 85% of families earning more than $200,000 do get benefits. Is this equitable access? So why do we believe Americans depend on worker health benefits? Well, in 1991, when the National League was studying healthcare, more than 77% of private sector jobs had it. Now, only 40% do, about half. And it's dropping every year. Newly hired workers don't get health benefits, nor do gig workers. Uber, Lyft, Grubhub, Instacart are all speeding this trend. Healthcare access today is far less equitable than 30 years ago. What's happened in public health? Now, this slide is complicated, so just note that the red line is lower and flatter than the other lines. The red line shows the US as an outlier. It's flatter because American life expectancy lengthened 3 years over the past quarter century, while peers with universal health care, all the other colors, live 4.5 to 6 years longer, with healthcare costing half as much. Treating healthcare like a market harms public health. Across the country, 166 rural hospitals have closed over the past 15 years. 47 filed for bankruptcy just in 2020. 40% of the rest are in dire straits. And the map at the bottom, purple means that more than half that state's rural hospitals could close soon. Fuchsia means 20 to 50% are at risk. But here's worse news. Hospitals that stay open are cutting services like behavioral health, like substance abuse, like maternity wards. And when maternity wards close, obstetricians and midwives relocate. On this map, the 90 counties in black show where hospitals have closed. The blue counties are where hospitals shut down obstetric services. No, they still open, but no maternity wards, no obstetricians, no midwives. What happens when Americans live 40 to 200 miles from the nearest OB/GYN facility? The red line shows the US trend. The black lines show a dozen peers. But according to the WHO, out of 183 countries, 157 decreased their maternal mortality between 2000 and 2013, when the US rate rose sharply. 157 black lines went the other direction. Of the 31 OECD countries, only Mexico has worse maternal mortality. Our Black mothers die at 3 or more times the rate of white mothers. Our rural areas are 2 to 3 times worse than urban areas. Our urban areas are 2 to 3 times worse than Europe's. 30 years ago, too many American mothers died of pregnancy-related reasons. Since then, many countries have halved their death rates. Ours have almost doubled. Now, primary care isn't profitable. It's reimbursed at lower rates. Medical schools discourage students from entering primary care. Yet the family doctor who knows you and your medical history is the backbone of good care, or was 30 years ago. Across the 3,000 US counties, only the pale blue counties have enough family doctors. Look for the pale blue counties. And note, much of rural America lacks broadband, so telemedicine isn't an option. This is why we're asking supporters of our healthcare concurrence to also support the digital equity concurrence. Now that we've set the stage for why a healthcare position adopted 30 years ago might need updating, let's discuss the New York State study and the proposed concurrence.
In 2019, there was much public discussion about adopting a New York State single-payer system. So the New York State Board recommended that the 2019 convention update our position on financing of healthcare. The board wanted to ensure members' support and understanding of the existing position and its consequences. By the fall of 2019, a committee was formed consisting of 7 members from various regions of New York State, including 3 PhDs and 4 with experience in the delivery of healthcare. We compiled and summarized health policy sources and then culled them down to 50 footnoted pages of study materials, which included the 2 rewritten positions. In late fall of 2020, we sent the positions and study materials to local leagues for concurrence by March of 2021. Of the 31 leagues who reported their discussions, all concurred with the healthcare position, and all but 1 concurred with the financing position. In deciding which language from the New York State positions to include in the concurrence statement, our Healthcare Update Committee, which is the group bringing this concurrence forward, looked at what was important to add to the U.S. position, removing redundant and state-specific language from what is being offered. When we look at the goals in the national position, they call for every resident of the U.S. to have access to a basic level of quality care, distributed equitably at reasonable cost to patients, individuals, and taxpayers. As we go through these points, we have put National League's wording in green and New York's in purple, so you can see clearly what we propose to add. Here's what we want to add: protecting the vulnerable, and by doing that, protecting public health. The pandemic has certainly shown us that we need to add telemedicine and other innovative delivery settings to our repertoire, and that we need to separate healthcare access from employment status. We'd add safe staffing, which is defined as a minimum number of staff with specified training required to care for a specific number of patients at specified risk and needing particular kinds of care, to keep patients safe and to keep staff safe. We spell out the right of patients to make their own healthcare decisions in consultation with whomever they choose. We call for cost controls to be evidence-based, to show that they actually reduce costs for the whole system and that they don't increase disparities of outcome. We specifically add that the single-payer concept is viable and desirable for achieving the League's national goals of affordable, equitable, universal health care, and that states can act as laboratories of democracy by piloting state-based programs of universal health care until such time that a federal program is enacted. Additionally, we also call for regular assessment and transparent administration of the healthcare system. This slide shows you the actual wording of the goals in the existing national healthcare position, which will not change. This slide shows you the actual wording of the language from the New York League's positions that would be added to the existing national position. It will be up to the national board to decide where to add this language. I'm going to read it to you. In goals, the League supports regulatory incentives to encourage the development of cost-effective alternative ways of delivering and paying for healthcare. Delivery programs may take place in a variety of settings, including the home and online, and must provide quality care, meaning consistent with standard of care guidelines by trained and licensed personnel, staffed adequately to ensure their own and patient safety. As public health crises increasingly reveal, a health program should protect the health of its most vulnerable populations, urban and rural, in order to protect the health of everyone. In addition, all programs should be evaluated regularly. Decisions on medical procedures that would prolong life should be made jointly by patient, family, and physician. Patient decisions, including those made prior to need, should be respected. This slide shows the current wording of the national position as it relates to the financing of healthcare. You will note that the current wording doesn't actually use the term single payer, although by calling for a national health insurance system financed through general taxes that provide universal access, it implicitly supports single payer. And the call for a transition from employment-based insurance to universal access is a call for the unemployed, the disabled, the young, and those whose employers don't provide health insurance to all of them have access to health care. This shows financing excerpts from the New York positions that would be added to the national one. The new position would make support for a single payer system more explicit and provide the rationale. It would strengthen the concept of separating health coverage from employment. We all recognize that Americans enjoy their mobility, and optimally, you'd have the same universal health care access regardless of the state you live in, with no gaps or waiting periods after you move. But this section recognizes the role individual states have traditionally played in piloting critical legislation, from seatbelts to gay marriage, from drug laws to environmental protections. It also recognizes the role that the Canadian province of Saskatchewan played in 1962, demonstrating the feasibility of its single-payer health care and prompting all of Canada to follow within a decade. It also calls for continued federal funding as a necessary part of the funding mix before the League will support any state bill. Some of the cost control methods listed in the national position, like mandatory second opinions and cost sharing, have raised total system costs. Remember, a concurrence cannot revise the wording of an existing position. It can add new wording that is not in opposition. Everything in the New York State position was reviewed with this in mind. This slide and the next one would add to the national position on cost control. Given the much faster than inflation increase in healthcare costs since 1993, when the national healthcare position was adopted, we in New York State required that specific cost control methods should reflect the most credible evidence-based research available on how healthcare financing policy affects equitable access to healthcare, the overall quality of care for individuals and populations, and the total system costs of healthcare and its administration. And that methods used should not exacerbate disparities in health outcomes among marginalized residents. The League has always called for universal access to healthcare, but our recent emphasis on diversity, equity, and inclusion requires us to pay more attention to the way that certain cost control measures unfairly impact marginalized communities. And by that, we mean rural residents, people living in urban healthcare deserts, people who identify as non-binary or LGBTQ, non-English speakers, the incarcerated, the undocumented, as well as people of color and specific ethnicities. Reduction of administrative costs is a key benefit in a single-payer system, since it eliminates the need for providers to employ a brigade of billers and coders to keep up with the requirements of multiple insurance, just as it eliminates the brigade of insurance administrators whose jobs depend on denying or delaying care. And we have the experience of single-payer systems like the Veterans Administration and Medicare, where administrative costs are less than 3% of total costs, not the 15 to 20% or even 30% for some private profit insurance. Negotiating volume discounts with pharmaceutical companies would likely achieve the 50% savings achieved by the Veterans Administration for its 6 million patients. These cost control methods reduce the overall costs of healthcare by reducing harm, such as reducing malpractice errors by systemic quality improvements, or preventing serious disease with early intervention and regular health education. Today, preventive care isn't profitable for private insurance. Paying for preventive care for patients who change insurers represents costs, but no savings. When everyone in a state is in the same insurance pool, preventive care reduces the total cost for that person and reduces the overall system cost. Similarly, most people who need assistance with daily tasks prefer to remain in their own home if possible. And paying for short and long-term health care is usually less expensive than institutionalization because the patient continues to pay for their own housing and food. This requirement for public participation in healthcare policy just makes explicit the League's long-standing support for public input into all government decisions.
This is the same page you saw before. Legislation that encompasses these additions, just one of them in a bill or many of them in a bill, will allow the League to advocate for reduced cost, improved public health, and making both access and outcomes more equitable. What has the pandemic taught us about our public health? That white dotted line shows the G7 average life expectancy before the pandemic. Our 6 peers outlived even white Americans by 3.5 years. And whites outlived Blacks by more than 3.5 years, who outlived Native Americans by yet another 3 years. The pandemic has worsened our health disparities. These columns show the worsening gap in American longevity. We died 2 years younger than peers in 2010 and 3 years younger in 2018. And in 2020, the gap rose 50% to over 4.5 years. On average, this is bad. For the marginalized among us, it's been catastrophic. Life expectancy in France fell 7 months. In Germany, 3 months. American whites lost 14 months, but Latinx lost 3 years. So did Blacks. American Blacks now die almost 10 years younger than G6 residents. Harlem, the South Bronx, the East Bronx lost 0.5% to 1% of their residents. It's like having 3.3 million Americans die. COVID has killed Black and Indigenous people at 3 to 5 times the rates of whites and at much earlier ages. So what caused most deaths before COVID? Well, the 5 leading causes of death are the same for all Americans: urban and rural, Black and white, but more Black Americans die and die faster at triple the rate of whites for respiratory diseases and 70% higher for cancer and strokes. And more rural Americans die and die faster. For cancer, it's 4 times the rate. Yet 86% of these deaths are preventable. 86%. These are people's lives, Americans. Americans aren't getting what people in peer countries get routinely: prevention, treatment, affordable care. Americans don't have family doctors. They live too far, and they fear getting sick. It costs too much. 2/3 of bankruptcies are caused by medical debt. I find these differences astonishing and tragic. For Americans, your zip code predicts how long you live. As we've seen, rural Americans have less access to healthcare, fewer hospitals, fewer primary care doctors, less insurance, and are more likely to die preventable deaths. Lack of access to healthcare kills. Ditto for Black and Indigenous Americans, and ditto to no access, even with telemedicine. And add in people doing essential jobs who must interact daily with the public, essential workers with no sick leave and no healthcare and no choices. This is why the American College of Physicians recommended rolling out COVID vaccinations by zip code, not age. Before we end, I'd like to add that COVID taught us about viruses riding subways, trucks, and planes, and inevitably reaching even remote Alaskan villages. Notice how much of Alaska has among the worst death rates. Ease of travel is one obvious reason why the US has experienced more epidemics over the past decade than anywhere else globally. But the WHO, which has documented about 200 epidemics per year recently, notes another reason. The US, despite its wealth, is seeing such devastation. The most difficult to control epidemics occur in countries with poor public health, among populations without equitable access to primary care. The League of Women Voters and the WHO have similar goals, but our league needs to become more explicit in our advocacy, hence the need for this concurrence. I'd like to end with a quote from the 2018 WHO Handbook on Epidemics. Universal health and health security are 2 sides of the same coin. Ultimately, the absence of universal health coverage for our most vulnerable people is the greatest threat to health security for everyone. The League's advocacy for equitable access to healthcare will certainly benefit marginalized Americans, but it will equally benefit vulnerable Americans, which means every one of us. This PowerPoint will be made available on request, but all of our concurrence material will be online for the next 5 months, being updated as we go. You'll find directions for filling out the National Program Planning Committee's online survey with links to the survey, so your league can support getting this concurrence and others discussed at convention. And while, of course, we hope your delegates vote to support adopting our concurrence, your support on the survey does not commit them either way. You can also find a link to the digital equity concurrence materials and the most up-to-date list of leagues who've already signed on. Right now, it's 39 leagues from 13 states, about 5% of the leagues in the United States, but we'd really like to get it to 10%. Before I say thank you, I'd like to just add, when you go to the online concurrence page, you will see it's long, but part of what you will see are the specific requests we are asking leagues to make. Get on your league's agenda and ask for their support. If your league decides to support this, please complete US program planning report. There is a link to it just below this. It tells you exactly how to fill it out. And we're asking you to put the exact language in the box into this box, into the question box, so that there is no confusion about what we're doing. So thank you, and we'll be happy to take questions.
Thank you very much, Barb and Judy. This was very, very informative. And as you can see in the chat, many people would like to have your slide deck. So if it's all right with you, I think in a follow-up email, we can send that out. Okay, thank you. Good. Well, we've got some very good questions here that I'd like to put out to you. One of the first ones had to do with the big difference in maternal death rate. And that they're wondering is what do other countries do that we don't do that makes ours twice as high?
First of all, most of the European countries have a long period of postpartum care. Mothers generally have 6 months to a year of paid family leave when they have a birth. So they have, besides having the health care, they have sometimes visits from like a public health nurse to actually see what's happening and to reassure or to tell people that really, yeah, what they're experiencing is a problem and they need to go and be treated for something.
Okay, thank you. Following along in that same vein of public health, a question came in when you referenced the regular assessment of public health metrics and coverage and funding. You know, around the country, we have seen a lot of public health departments coming under fire during the pandemic and public health directors resigning. Do you think that the position should be strengthened more with regard to public health, or do you think some of the elements that you included really start to give us more legs to stand on in our advocacy for public health?
Both. It is my belief, and I don't have a degree in public health, and I've not spent a lot of time studying public health other than comparatively, but our public health suffers both because the public does not have access to doctors, and it suffers because it doesn't have funding. And when you don't have a population that understands what public health departments do or why they exist, it is very hard for them to survive something like the pandemic. And it's my personal belief, and I saw one article that mentioned this, and I've been chasing the reporter and haven't been able to reach the reporter. It is my belief that when people do not have family doctors that they trust, and they go to clinics and it's a different doctor all the time, or they have employee-based insurance and the network keeps shifting, so you keep shifting your policy and your doctor. If you don't have a doctor you trust, why should you trust doctors?
Mm-hmm. That relationship of people with their primary care.
Yes.
And I think, as Barb pointed out, in other countries, that's the real emphasis of their public health, of their system, rather than on specialists, which you see once or twice. Mm-hmm.
Yes. And I would just, to affirm what Barb said, one of the biggest our infant mortality is also astonishing and awful.
Yes.
And infant mortality is most affected by regular skilled prenatal care, regular skilled postnatal care, because when you take care of the mother and the mother is monitored and taken care of, it takes care of babies. And it probably helps that there is essentially subsidized or free daycare in most of these countries, so that if I have a 2-year-old or a 3-year-old or a 4-year-old, I can focus on my infant and not have multiple children all demanding my time.
Yeah, yeah. All right, and from Carolyn up in Alaska, she asks how to deal with the battle of the ideology of socialized medicine in America. This is something all of the single payer people have worked for years around the messaging.
And the messaging is difficult because people with a real stake in the profit system that our insurers have like to sling that word of socialized. But I think what we have to say is it's universal care and it's supported by everybody. All taxpayers pay in. And that it really is to the advantage of everybody. I mean, we've seen that in the pandemic, that, if you are in contact with other people, you need them to be healthy too.
I also pick up that New York Health, 2 of the legislators in our assembly did a short video, which we should send to Linda to send out. Now, this is about New York Health Act, not about anything else, but it's 2 firefighters, two assembly people who are dressed up like firefighters, talking about what privatized, capitalistic, good kind of market economy firefighting would be like, rather than terrible socialized firefighting. And not their building, if you don't have insurance, we're not going to fight your fire. And the way I often pick up the socialized medicine is, well, we have socialized police and socialized schools and socialized firefighters. We have a socialized military, and we have socialized medicine effectively for all of these groups. So what you're saying is the only people who shouldn't get socialized good like this are people who actually work for a living in the private sector. Because in fact, Medicare is socialized, the VA is socialized. And we have, when it is around the public good and it is cheaper and more efficient because it's not a market, healthcare isn't a market. When I get sick, I go to a doctor and I trust the doctor to tell me what's wrong with me. That is not how I buy a car. I do not go to the dealership and say, hey, I think I might need a car. What do you think? What kind of car do you think I need? An expensive one or a cheap one? Oh, the most expensive one with all the highest stuff? Oh, okay, I trust you because you're the expert. That isn't how car dealerships work.
Thanks, Judy. And there's also just a question repeating, how does the league support putting 2 concurrence ideas into the form? Would you review that again?
So it is our understanding. Go ahead.
Go ahead, Judy, go ahead.
It's our understanding that there are 2 boxes that can take suggestions from a local or state league as to what else they would like to see on the proposed on the recommended program for the convention. So what we're talking about when we say recommended program is essentially the agenda to be discussed and voted on. Each of those boxes will hold 300 words. And each of the concurrences for healthcare and for digital equity is under 120 words. So you could drop in 2 of them and have room for another few sentences in one box. And then you have room for as much as you can fit in the second box. My league will also be probably doing supporting 3 concurrences. We will put 2 in one box and 1 in the other.
Here's a big
And
question.
that's essentially what we've been working on.
Yeah. Are there any people who would like to unmute and ask a question directly? I've been pulling questions from the chat, but it occurs to me, maybe some of you would like to actually speak. Anybody? And Barbara, can you help me look if there's hands raised?
Yes, I will.
Okay. Well, while we're waiting for you to think of your question, one other question came in. It has to do really with the tremendous amount of money that's already flowing around in our healthcare system. Do you have any ideas about how the League and other activists can combat this large amount of money in the vested interests?
Well, what I would say, and I've spent this morning on email with a couple of friends in New York who are disappointed because we don't have, we have a majority of sponsors in each chamber, and it's not clear that we have a majority of votes. What I try to say is, as of now, corporations don't vote. They can give campaign donations, and PACs can give campaign donations, but they can't vote. Healthcare is part of the conversation because of the pandemic. Most people realize how disastrous our response has been. They don't realize that the United States has lost more people per 100,000 than any country other than Russia. I mean, there are countries in Europe where their population grew during the pandemic. We lost people, and the reason for that is that the pandemic is around us and people care about talking about healthcare. So if you can get voters to realize what they could do about it, I think you can get voters, elected representatives, to vote properly, but only if there is mobilized groundswell. Carol Mattoon, you have your hand up? You're muted.
Someone wrote in there that they would like the script as well as the slides. Will that be available?
Probably. Right now it's in colloquial. We might need to clean it up so that it's in standard English.
We'll give you time.
But actually, I think that if you have the slide deck, there are notes that
Yes.
are at the bottom that are most of the script.
That's true. Good save, Barb.
Yeah.
Thank you.
Thank you.
All right, Barb, are you seen any other questions coming through that I have missed?
Yeah, I'll send them to you.
Okay.
So I see one that says, how do we respond to people who say we've got to be loyal to the ACA, to the to Obamacare? And my reaction to that is legislation isn't loyalty to one bill over loyalty to another bill. For the League, what we look for are advocating for legislation that will serve the public good. And I don't know how much activity we should spend on healthcare at the congressional level right now. I would think it is very important to spend our activity at the state and local level, so that local communities and states think about how they can save costs and improve healthcare across their populations. Because I think there are very few states who aren't at least a little worried about it, regardless of what their governors say.
Okay. There's one more question I saw here asking about ways that single payer would be paid for. We don't usually go into that in our positions, other than our original position says would be paid for by taxes. Did you look at that any further in your study, Judy and Barb?
So the answer is, so let me start by saying we didn't show a slide that shows that the United States although Barbara said this, currently pays more in taxes for our healthcare than all of the developed world other than Switzerland pays in taxes per capita. Oh, I've got that back. The rest of the world has a certain amount they pay in healthcare total per capita. You take the total expenditure for the country, you divide it by the population. That's how much they spend for healthcare, either in taxes or out of pocket. In the United States, if you take the amount that we spend on taxes right now, it is more than what those countries are spending for all of their healthcare. Plus, we spend another $5,000 out of our own pockets individually